Hello, my name is Broderick Morgan, and this is my change proposal presentation. My problem is increased admission rates in the NICU for late preterm infants, or those infants are between 35 weeks to 36 plus 6 weeks gestation. This creates a problem related to staffing requirement needs to care for these patients, the anxiety and stress created from mother-infant separation, and decreased bonding times, such as skin-to-skin interaction and breastfeeding. It also creates unnecessary burden of cost to families and leads to increased length of stay for the organization, further straining the shortage of nursing staff required to care for these patients. My proposal solution is to create an environment or a transitional care unit that would allow this vulnerable population more time to transition instead of transitioning them in the NICU setting, and provide early stabilization interventions through additional training for the staff. This would improve the safety and quality of care of the patients and promote family-centered care through mother-infant bonding and breastfeeding. Decrease the burden of cost to the families and organization, as well as decreasing the length of stay for these infants. In my opinion, this problem is related to both micro and meso systems levels of care. It is an interdepartmental problem, but it affects more than just that department. Labor and delivery nurses should not be responsible for late transitioning and prolonging the transfer process to the mother-baby unit of infants with their mothers simply because the NICU lacked the staff or bed space to admit a patient that was borderline for transitioning. Mother-baby nurses should not have to deal with separation. Mothers of the babies should not have to deal with separation anxiety experienced due to the transition in the NICU related to delayed intervention by staff to support a successful transition. By creating this additional level of care, things like mismanagement or delays in care can be avoided, and you promote family-centered care as a goal of the organization to limit unnecessary separation of mother and infant, and promote skin-to-skin interaction as a benefit to transition, which has been proven to decrease mild respiratory distress, provide adequate temperature regulation, and promote a strong immunity through passive immunity from contact with normal flora present on the mother's skin. Complex adaptive systems and barriers. Working within a system can have a wide range of benefits to the implementation of my problem, such as a better understanding of the workflow issues, improved organizational communication, improved patient care outcomes, decreased length of stay, and better overall patient satisfaction. However, barriers can still exist, such as lack of leadership support, staff resistance, shortage of resources and revenue to implement the change, and uncertain roles and lack of accountability in the unit's overall culture. SWOT analysis. What I've learned from my assessment and SWOT analysis is that this organization is the largest health network dedicated exclusively to children and expectant mothers. It provides a high level of quality care that is backed by research, innovation, and discoveries coming from a leading university and top-ranked academic medical center. It has expert positions in every pediatric specialty and is ranked in the top 10 in specialty areas of neonatology, pulmonology, and endocrinology. The organization provides housing through the Ronald McDonald Foundation to foster a family-centered care environment for families that live more than a 50-mile radius away from the facility. Weaknesses include high turnover in staff related to nursing staff shortages, which results in inconsistent caregivers providing care. Specialized hospitals tend to be more expensive, and the fact that it is a teaching hospital where residents are used to provide care can be seen as an obstacle to care for some parents. Opportunities include state-of-the-art care not observed elsewhere, collaboration with other hospitals in the area to knowledge share, improve patient satisfaction surveys through the promotion of family-centered care. Threats are pressure to reduce costs from competing hospitals, failure to evolve with changes in technology and staff education, and staff retention. Change theory. Initially, I had chosen Lewin's change theory based on unfreeze, freeze, and refreeze concept. To me, Lippitt's change theory is most similar to the nursing process and something that I can relate to. During the assessment phase, Lippitt incorporates Lewin's unfreeze stage and Rogers' awareness phase, but he offers much more of a framework for change agents and includes an assessment of motivation. To me, this was important because I want to make sure the motives are justified and that they are serious about the implementation change and is willing to do the lead work to ensure that the change is implemented. And once it is complete, they step back and let the change implementation become part of the organization's culture. Quality and safety outcomes. Quality and safety outcomes include effective and efficient care through education and training of staff, time-managed care, decreased length of stay, family-centered care, minimize separation between mother and infant, evidence-based practice, vulnerabilities associated with delayed preterm infants, improve patient care outcomes, decrease NICU admissions and length of stay, reduce risk to patient, early intervention and identification of high-risk newborns. Nurse-sensitive outcomes, things that are important to the nurses. Improved evaluation and assessment tools, additional training and education that allows them to better do their jobs. Decreased workloads, less admissions in the NICU means less IV starts, less specimen collections, and less antibiotic therapy. We all want to improve patient care outcomes, promotion of family-centered care, and nurse autonomy. Improvement model. My improvement model is the triple aim. Improvement model of because it involves an improvement model of a particular patient population, in my case, late preterm infants. It improves the overall care experience of the families, family-centered care, and it's cost-effective, decreases the burden of cost to the families as well as the hospital. Financial implications. Cost-effective care that requires a small investment. Starting budget of $125,000. Startup costs approximately about $25,000. This includes equipment and supplies. Operating costs approximately $72,000. It's a small fraction of the total NICU operating costs in just one day. Admission rates are half that of the NICU, which are $3,000 a day. Budget expenditures. So as you can see from this slide, on this chart, this is a chart of my budget expenditures. The transitional care unit will be housed in the newborn nursery, so this cuts out renovation costs. My most expensive purchases were my radiant warmers and my portable monitors, which are one-time expenses apart from maintenance. From the chart, you can also see that medical supplies and emergency equipment account for the largest portion of my budget, but this is an annual expense. As mentioned earlier, my operating cost is around $72,000, give and take a couple of $100. My return of investment is just under 30% for the first year. However, this number goes up to around 70% when you subtract the startup cost of $25,000. With a monthly revenue of about $10,500 based on about 20% of all possible NICU admissions will be admitted to the TCU. This gives you an annual revenue of $126,000 in the first year. Implementation and evaluation. My implementation strategies include creating an awareness. Bring awareness to the fact that the NICU admission rates are being affected by the lack of early intervention in this population during the transition phase. Change agents help to build knowledge and commitment by promoting action and adoption of the change and gradually winning over holdouts by pursuing integration and keeping their project in the forefront by posting reminders and having meetings so that all parties involved are familiar with the implementation process. In the evaluation phase, start by creating a logic model and establish indicators and evaluation questions related to those indicators, such as how many staff will be trained and how effective is that training. Is there a reduction in the number of NICU admits post-implementation? Is the data being collected from credible sources to reduce bias and increase validity? In other words, is it measurable? Is it cost effective? $125,000 seems like a lot of money, but to a large organization, that's a small investment for better patient outcomes. Upon completion of my evaluation plan, dissemination and reporting of my plan to all appropriate audience in comprehensive and systematic ways is important, as well as deciding who will present the results. I would choose strong advocates for the proposal to present the plan to the implementers, which include the NICU director, NICU managers, clinical nurse specialists, neonatal nurse practitioners, and all the NICU physicians. Once the evaluation is thoroughly reviewed and the concerns addressed, then the proposal can be carried through to the next set of stakeholders, which are the decision makers, such as the NICU director, chief nursing officer, and the chief medical director, which is responsible for approving the proposal. Lastly, the plan will be viewed by key stakeholders, those responsible for funding the proposal, and in my case, this would be the hospital's organizational system and its partners. This concludes my presentation. Thank you.